educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, everybody, and thank you for joining us today for our HealthyU Webinar Series. Today's topic is saying goodbye to varicose veins. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of the screen. We will answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous. Today's presenter is Dr. Michael Dayan. Dr. Dayan earned his medical degree from the Accelerated BA MD program at Case Western Reserve University School of Medicine in Cleveland, Ohio. He completed an internship in general surgery and residency in diagnostic radiology at Rutgers Robert Wood Johnson Medical School in New Jersey. He then completed his fellowship in vascular and interventional radiology at NYP Weill Cornell Medical College and Memorial Sloan Kettering Cancer Center in New York City before joining the staff at Mather Hospital. Dr. Dayan also holds an MBA in technology commercialization with interest in healthcare operations and analytics. His clinical expertise includes all aspects of diagnostic radiology, interventional radiology, and interventional oncology. Dr. Dayan is a core faculty member in the subdivision of interventional radiology and an assistant clinical professor in radiology at the Zucker School of Medicine. All right, Dr. Dayan, do you want me to share the slides or would you like to share them?
I'll go ahead and do that.
Okay, no problem.
All right, good morning, everyone. My name is Dr. Michael Dayan, and as Mr. Anderson said, I'm a vascular and interventional radiologist here at Mather Hospital in Northwell Health. We are primarily hospital-based, and we have our offices across the street from the hospital on North Country Road. Today, we're going to speak about minimally invasive treatment of varicose veins and spider veins as well. We're going to start by talking about what varicose veins are. And that's essentially a condition in which superficial veins, or veins that are right under the skin, become enlarged and tortuous. They are visible to the eye. You can feel them. They often have a very ropey, textured feel. And by definition, they're over 3 millimeters in diameter. You can see the example of the patient here with large varicose veins in the posterior thigh. So a little bit of anatomy. There are two systems of veins that are in the lower extremities. One of them is the deep system, which if any of you have heard of DVTs or deep venous thromboses, that's where about 90% of the blood flow goes through the leg and returns blood back to the heart in order to be ultimately recirculated. The second system is the superficial system, and that's a system of veins that just lies right under the skin, and that basically drains a more superficial area instead of the deep muscles. And that also communicates via these very small perforating veins to the deep veins. I don't know if you folks can see my mouse, but for instance, right over here is the deep venous system, this one line over here, which is the femoral vein. The ones that are more highlighted on the outsides, those are the superficial veins. This right over here is the great saphenous vein, and it connects or communicates with the deep venous system by these small perforators. Here is the leg with another at another angle, and this is a superficial vein. This lies right under the skin. This is the great saphenous vein and a number of side branches that come out from it. It also sneaks around the medial aspect of the calf, or the middle aspect of the calf. And on the lateral aspect of the calf is this small saphenous vein, which you can see here. So this is also a superficial vein. So two systems, and in this talk, we're primarily going to be discussing the superficial system, or the system of veins that lies right under your skin that you can see. The deep venous system is a system that you cannot see, and that's a system that directly communicates with, ultimately with the heart, and that's where people get DVTs or blood clots in their deep veins, and if that dislodges and goes to their heart or lungs, that is a pulmonary embolus, and I'm sure many of you folks have heard of that. But this is a different system of veins. Although they communicate by tiny little tributaries, they're really two separate, disparate systems. So going into some epidemiology, varicose veins, prevalence-wise, is about 10 to 30% of the global population. So that's certainly over 1 billion people. In the United States, 22 million women and 11 million men are affected. So as you can see, there's certainly a gender disparity there in terms of a number of individuals affected. It is more common in Western countries, and we will go into some of the causes and why. The female predominance is primarily due to pregnancy and due to circulating hormones, particularly progesterone. The pregnancy aspect of that is actually because of the pressure from the fetus and from the overall gestation on the venous system, which causes, when you have increased pressure on the venous system, it causes some amount of backup of the veins, and ultimately through those tiny tributaries, the superficial veins will not drain as efficiently and will become engorged, and ultimately, once they become enlarged for a significant period of time, will be essentially permanently compromised. So particularly individuals that have a number of pregnancies over time, each time they develop something called venous hypertension, or the pressure on the veins from the pregnancy itself will cause the pressure in the veins to increase, and that compromises their integrity over time. As we progress in life, the integrity of the veins also decreases and their elasticity decreases, and obesity, for similar reasons to pregnancy, can increase the risk of developing varicose veins because of what is called venous hypertension, or increased pressure in your veins. Needless to mention, billions of dollars of lost productivity and wages annually, over $1 billion in the United States alone, from issues related to varicose veins. So more into the causes of varicose veins. We talked about the increased pressure in the veins, and this is often superimposed on weakened walls. So the primary cause is really increased pressure, which leads to decreased elasticity or weakening of the walls. And once the walls are weak, what that brings about is it compromises the valves. And if you folks can see my mouse here, you can see that basically this is a healthy system where valves open to let blood flow through back to the heart. And here the valves close to prevent blood from going back down the leg. You want blood to just flow one way, which is to the heart, rather than back down the leg. When you have varicose veins, the walls of the veins, the elasticity of them are compromised, and that also prohibits the valves from properly closing. And you can see here on the right where the valve is incompletely closed, and you have reversal of flow of blood down the leg instead of up towards the heart, and that basically causes the veins to enlarge because they become engorged with back-flowing blood. And in a snowball effect, that further damages the veins wall and elasticity. Of note, valves are really absent above the level of the groin, so valves are really more of an extremity phenomenon. So you see it in the legs, but they are not seen above the groin. And the phenomenon that we discussed, where blood reverses flow, and instead of going up the leg, instead the valves are compromised and the blood flow reverses or goes back down the leg temporarily, is called reflux. Similar to gastric reflux, where the gastroesophageal junction is compromised and there's gastric juices reflux into the esophagus. more about varicose veins. As we discussed, the elasticity of the veins are compromised, and there's some genetic predisposition or family connections as well. And that's something to keep in mind when initially seeking consultation for these. We go into the family history and any potential genetic predisposition in terms of vascular issues that run in the family. Estrogen or progesterone, whether directly interacting with some of the fabric of the veins walls, or even indirectly producing compromise to the veins walls. That's certainly going to be an issue that leads to the increase in prevalence amongst women, as we saw on the slide earlier. Also interesting, but less scientific, are wearing tight undergarments, constipation, or even standing for extended periods of time can also be contributory. The tight undergarments are thought to basically constrict the outflow of blood from your leg into the systemic circulation. And when you're basically constraining that, the pressure within the veins increases. So tight undergarments really put some pressure on the veins. Also constipation. When you're constipated, the individual tends to strain for prolonged periods of time, and that straining increases the pressure within the veins. Similar on thought, the standing for extended periods of time also increases pressure within the veins, which can be contributory, which is why many patients say that after a long day of particularly involving standing and not moving, so individuals that stand, for instance, in an operating room in one place, can have their varicose veins be very accentuated by the end of the day due to the increased pressure in their veins, superimposed on already compromised walls of the vein and the valvular prolapse, as we talked about before. You can see here a schematic of normal blood flow. This is basically going to be the leg, and you expect the blood to flow back up the leg and back to the heart. But here you have a very tortuous or snake-like vein, which is enlarged, and the valves are not properly closing to allow the blood to flow in one direction, and you have a reflux back down the leg. Some of the symptoms to expect are bulging bluish veins and swelling in the legs. Aching pain is a symptom that is very commonly seen in patients, and is particularly described as a dull ache worsened by prolonged standing. And improving that would be walking or elevating the leg. So that's a typical part to the story of when we get our patients. A lot of them describe dull aches in the back of their thigh or the back of the calves, but it can be in multiple locations throughout the leg. Feeling of heaviness in the legs and the feet may worsen with menstrual cycle, pregnancy, and in response to hormone therapy, including oral contraceptives. So don't forget that even postmenopausal hormones may cause some accentuation of varicose veins because of the effect that the hormones have on the vein walls. Patients may also experience itching and skin color changes around the veins, including nighttime leg cramps. When individuals present to our office, they go through a typical evaluation for both varicose veins, spider reticular veins, and also even an arterial vascular assessment. So we start with a history of present illness, which is why an individual has decided to seek consultation about what their pain may be like in their lower extremities, what they're feeling in terms of the tortuosity of the varicose veins. They may express discontent about the cosmetic appearance of their lower extremities. It may be itching, it might be swelling, it might be redness around those areas. So a number of issues individuals will come and they'll describe in detail, and we'll obtain those histories in great detail to better understand what the causes of their complaints are and what the best solution is to help resolve it. We also go through a detailed family history. Family history plays a large part in the development and progression of varicosities in the lower extremities, people that have collagen vascular disorders, people that have a history of varicose veins in their lower extremities, and de facto reflux. So those are things that make a lot of difference. Past medical history, whether or not individuals have had treatment for this before, what medications they take, whether they've had blood clots in their deep veins in their legs before, or pulmonary emboli. All of these things essentially play into the consideration of that evaluation. We examine the individual physically, particularly their lower extremities, to better understand what exactly is transpiring, whether they have varicose veins, spider veins, which we'll talk about momentarily. And so we go through our venous evaluation. Part of that venous evaluation is done while the patient is standing upright. And that is to employ the benefits of gravity to actually enlarge the veins further so that we can really understand their geography and anatomy, location, depth. And we also provide a SEEP score, which is essentially a venous disease score that leads us to understand how the vein issues are impacting quality of life and what some of the risk factors are if we don't do anything about them. We also perform vascular exams, arterial vascular exams, including obtaining pulses in the feet and ankles, and we also do a skin sensation assessment to make sure that the arterial blood supply and the venous blood supply or venous drainage are as we'd expect, and they are not compromised in any meaningful way. Many times, for most, we recommend mapping ultrasound of the lower extremities, and as you can see in the photograph in the bottom right-hand corner, there is a ultrasound tech which performs this non-invasive test where part of it can be done actually while standing, and part of it can be done laying down as the patient is here, which starts all the way at the upper thigh, close to the groin, and the ultrasound tech will essentially map the varicosities in the lower extremity and also apply pressure at various points, because the ultrasound tech wants to understand when there is pressure applied to the veins, like the ones we apply in real life, such as standing for prolonged periods of time, such as the obesity, such as pregnancy, such as straining while constipated. We want to recreate that in this ultrasound test to understand whether or not there's reflux or blood flow going the wrong direction in the leg, which is down the leg. So the ultrasound tech will push down a few times and then take measurements of the size of the veins, and also has abilities to determine which way the blood is flowing in the lower extremity. Typically speaking, the great saphenous vein, which is the largest superficial vein in the lower extremity, is measured, and a 5 or 6 millimeter measurement is the minimum threshold where we determine that to be enlarged and abnormal. The ultrasound tech also assesses for reflux, like we discussed, or wrong direction blood flow in the leg, and that is calibrated at greater than half a second in duration after augmentation manually, which means after they push down. So they make these assessments to provide the radiologist or interventionalist criteria in which to determine that there is something pathologic or there is something abnormal with the superficial veins. And again, the great saphenous vein, which is this large one over here, is by and large the greatest culprit in terms of varicose vein development. And you can see that's really the dominant superficial vein, and all of these side branches come about from that. The small saphenous vein is only a small aspect of the lateral calf and ankle, but the great saphenous vein is the majority of the thigh and calf. So what can we do for varicose veins? Well, one of the treatments we have is endovenous laser vein treatment, or abbreviated EVLT. When the patient arrives, the leg is sterilized, and a small amount of numbing medicine is given using an ultrasound, and a needle is poked through that area into most commonly the great saphenous vein, which is a large caliber vein, and a tiny fiber is threaded through the vein all the way up until the groin. This is something that the patient typically does not feel because the inside of the vein doesn't have nerve endings, but it really just the pinch and burn from the numbing medicine is the most stimulating part. And we thread the fiber using an ultrasound all the way up until the beginning of the great saphenous vein at the groin. And then we activate the laser, which causes the vein to collapse and eventually disappear. Some patients, when the laser is turned on, describe somewhat of a warm or even a mild burning sensation, but it's a very tolerable and very quick. It usually, the whole access and threading lasts about 10 minutes, and the laser is only turned on for about 5 minutes. So it's a very comfortable procedure and is really all done through just a tiny needle prick. The goal of this is to ultimately sclerose the vein or make it collapse and disappear. And you can see here to the right-hand side the point of entry and also the laser fiber within the vein itself. And here's the vein closing down around the fiber. Another therapy is called sclerotherapy. Claravane is the name brand that we have here for this type of treatment. Very similar to the laser treatment in terms of the actual technique and access. It's really just done through a tiny needle prick in the leg after giving a touch of numbing medicine, and a fiber is again threaded all the way up that great saphenous vein to where it begins around the area of the groin. And instead of there being a laser, the only difference with this is that this point at this very tip spins inside of the vein and also squirts out a small amount of a liquid sclerosant, which shuts off the vein. So it macerates the lining of the inside, damaging it, and the sclerosant denatures the lining of the vein by acting as an irritant. So very similar in terms of technique to the laser, in terms of what the patient experiences and sees, but just the mechanism is a little bit different. The first one was a laser, which basically denatures the entire inside of the vein in one shot. This one is just slowly pulled through the vein, damaging the inside lining and denaturing it with the liquid sclerosant that's injected while the tip is spinning. So just different mechanisms to achieve the same end. The third technique is actually called microphlebectomy, which is a minimally invasive procedure that actually removes the veins physically. This is something that our practice does not do. However, it is within the realm of things that can be done for varicose veins. So I would like to include it in this talk for you folks to see. It's a bit more invasive, as you might see and imagine. And it really involves just a few pokes of local anesthesia wherever the varicose veins are, and a little what they call a stab incision, or a teeny cut about 3 millimeters across with a scalpel. And the varicose vein is actually manually removed, as you can see in this picture, and basically just pulled out piece by piece. And that is also very well tolerated by patients. It seems a bit more stimulating and involved, but well tolerated. And it is not something that our practice employs. So how about some of the aftercare? Aftercare after any of these procedures, whether the laser, whether sclerosant maceration with Claravane, or from the microphlebectomy, involves compression stockings of medical grade. That means 20 to 30 millimeters of mercury of pressure immediately after the procedure, which we apply on. And we recommend that being on 24 hours a day for 2 days, even during sleep hours. Alternatively, practices sometimes use ACE bandages or even compression bandages. We recommend walking immediately after the procedure, but please refrain from aerobic exercise for 2 days. So over the period of time that the compression stocking is on full time, no aerobic exercise, just simple walking. After the 2-day period elapses, aerobic exercises can begin, but we recommend compression stockings for 1 to 2 weeks during daylight hours, so the compression stockings can be removed when the individual is sleeping. We also recommend warm or hot baths, refraining from that for 1 to 2 weeks, and avoidance of direct sunlight for 4 weeks. What to expect? Wheals. So wheals are the sites of the injection. Redness will disappear in the 1 to 2 day point. Bruising in the 1 to 3 week point. So it is perfectly normal to bruise at the sites, particularly with the phlebectomy, which was the manual removal. As you might imagine, the manual removal happens at many sites through the leg, as opposed to the laser or Claravane, which we do, which basically happens from one entry site. So if you do the microphlebectomy, which we don't do, there is significant bruising, but that usually tapers off anywhere between 1 and 3 weeks out, depending on a multitude of factors, including clotting factors with the patient and even skin tone. There may be some brownish discoloration from blood deposits at the site of access that is expected, and that should resolve within a week. That's essentially a bruise. And after a few weeks, you should really have the cosmetic and medical result that one would want from this, as the veins are all thrombosed and disappeared. Insurance coverage, which many people wonder about. Varicose vein treatments are robustly covered by most commercial policies, including Medicare. Typically, 80% of the Medicare approved amount is paid. There might be some co-insurance depending on what policy you have, and a co-payment. And if you have a deductible, that will apply as well. But the vast majority of these are covered as to the 80% point and sometimes beyond. Some of the landmarks that we have to achieve or establish prior to insurance approval will be annoying or painful symptoms to the patient, which typically is not a problem given the fact that they've already sought consultation with us. We have to identify venous reflux. So during the mapping ultrasound, the report will demonstrate venous reflux if present, and that is going to be diagnostic and part of what Medicare uses for approval or denial. And also a specified time of unsuccessful conservative management. So the insurance approval will not come right away, but the individual will have to demonstrate that they have used compression stockings, they have attempted a diet/exercise plan to reduce weight and therefore reduce pressure from their veins. And once that fails, typically after a 1 month period, insurance will thereafter give us a green light to give coverage for the varicose vein treatment. Then we could go into spider veins. So spider veins are tiny branching veins right under the skin surface. So varicose veins, in contrast, are going to be greater than 3 millimeters. You can feel them, the varicose veins. The varicose veins were snake-like, rope-like, and can cause significant pain, heaviness, swelling, and cosmetic issues. Spider veins, in contrast, as you can see here, are about 1 millimeter in diameter, and these are at the very superficial aspect of the skin surface. On the spectrum, reticular veins, which you can see here in the left-hand image, are slightly deeper and may have a bit of a more rope-like appearance, and they're larger than spider veins. They're usually about 1 to 3 millimeters. To put everything into perspective, spider veins are going to be the most superficial and the smallest at 1 millimeter, and the spider veins are in the large image to the right. Reticular veins are a little bit larger, but still pretty superficial under the skin surface. And you can see that right over here, they're less than 3 millimeters, but typically greater than 1 millimeter. And varicose veins was the first part of the talk, which were greater than 3 millimeters and rope-like, which you can feel. Some of the treatments for spider veins include laser therapy. So here's an example of a laser therapy machine. These are calibrated for a specific wavelength of laser light. And you can see here that the proceduralist is just essentially honing the light on an area of spider veins here, and will pulse that laser to eventually make these veins collapse and disappear over time. The sensation is very similar as described to dermabrasions on the face. It's a very transient burning feeling, and it's just pulsed in such a small period of time that it is generally very well tolerated. There is no burning on the skin surface. Of note, the laser takes usually more than one treatment for areas of spider veins. It's non-invasive, but it generally takes about 2 to 3 sessions to employ maximal effect. Sclerotherapy, or injecting spider veins, is a fantastic solution to making spider veins disappear. These are simple injections within the spider veins, and they are generally done in 2 to 3 treatments spaced about a month apart. The goal is to produce an inflammatory reaction or an irritant within these tiny spider veins, and they just close down the vein, replacing the blood within them. You will lie on your back on the table generally with your legs slightly elevated or in a frog leg position, and the doctor will just cleanse the area and target the area with a very, very small needle. It's one of the smallest needles manufactured, so these are very well tolerated without any anesthetic at all. So, certain details, I do give these talks to some other physicians as well, so I do include some more detailed slides within them, like this. This gives you the sclerosant that we use, or what we inject within the veins. We use sotradecol, otherwise known as STS. It generally comes in a 1 or 3% solution, which we dilute with some saline to a less than 1% solution. So we generally go anywhere between 0.25 and 0.5% for most spider veins. Patients tolerate it very well. It does a fantastic job when injected. Very low risk of necrosis or breakdown of the skin. Low risk of increased pigmentation after injected. And I have a little video for you folks to see one of the most gratifying aspects of this procedure, which is the injection of the STS within a spider vein. So here it is. So here's the proceduralist beginning to inject, and you're actually going to see them disappear right in front of your eyes. And there it is. So that whole area of spider veins just disappeared, and that is thought to be a permanent solution. There's a certain number of areas that are typically done at once just for ease of tolerance. And if any of these areas return, or the peripheral areas return with spider veins, they can also be injected. But as you can see, one injection covers a whole tangle of them. What to expect? Similar to treatment for varicose veins, these injections for superficial spider veins may bruise for a couple of weeks, depending on blood clotting factors in the patient, depending on their skin tone, depending on whether they're taking blood thinners. So a number of factors that play in, and those brownish colorations are basically bruising. And within a couple of weeks, the veins should completely disappear. That's a very conservative statement, because as you can see, they truly disappear immediately, as you could see in the video. Oftentimes, you might see 1 or 2 tiny strands of veins that appear to linger, but actually will disappear with time. Similar aftercare to the varicose veins, but with laser, you need even less. So we just recommend elevation of legs when seated, and medical grade compression stockings for 3 days. After that, there's really no requirement or recommendation, but we always do recommend the use of compression stockings as much as possible during the waking hours of the day. I wear them myself almost every day. For sclerotherapy or the injections for spider veins, we recommend compression stockings for 48 hours, including hours of sleep, and then for 1 to 2 weeks after for the waking hours of the day. Sometimes you might see ACE bandages or compression bandages, works just as well. We recommend walking, but just refraining from aerobic exercise for a couple of days. And particularly for spider veins, we recommend avoidance of sunlight for at least 4 weeks, but preferably greater than 6 weeks. A lot of the reason for that is that the small residual veins, which are beginning to disappear, are known to be very photosensitive or sensitive to the light, and they may wind up lingering around permanently because of the exposure to UV. So we recommend staying out of the sunlight. Similar regimen for prevention of spider and varicose veins to come back. The compression stockings during the waking hours of the day as much as possible. When you're sitting down, elevate the legs. Maintain good weight control. The one's weight that is carried by the legs plays a huge part in venous hypertension, or the pressure within the veins. And when the pressure within the veins increases, it compromises the wall of the veins permanently, leading to varicose veins, spider veins, and those intermediate reticular veins that we discussed earlier. We recommend exercise, and if possible, avoid wearing high heels because the larger veins cannot fully empty as well when the foot and calf are put under the stresses that they are with high heels. So here's some results with spider veins. You can see this individual has a number of reticular veins posteriorly here, some varicose veins along the side, which have been treated. And here are the spider veins. And here's the after result, which is markedly improved. This individual had the reticular veins injected as well. So these are the reticular ones, the ones that are a little deeper, and the spider veins. Here's another individual that had these spider veins injected. And here's the after result, which is a phenomenal homogeneous appearance of their lateral thigh. A couple patients with varicose veins before and after. Very large great saphenous vein distribution varicose veins, which have been treated and are markedly improved. Same with this individual here. Great saphenous vein distribution, markedly improved. Same with this individual. Really nice results. And these individuals were actually all treated with the laser. And this is who we are. Mather Interventional Radiology Associates. We are based in the hospital, and our office is across the street in 70 North Country Road, Suite 302. There are 3 of us. So that first one on the left is me, Dr. Michael Dayan. My 2 partners, Doctors Mohammed Bilal and Kenny Lean, are fantastic colleagues. Combined, we have over 5 decades of experience in vascular and interventional radiology, including accessing the smallest of blood vessels, which we do on a routine basis using imaging, which is essentially the crux of our entire line of work. We have a residency, which we house ourselves. And so teaching is a huge part of our daily cadence. And we all have faculty appointments at Zucker School of Medicine at Hofstra. And